By definition, pain is subjective. It's defined as an experience. It has sensory and emotional aspects. It does reflect activity in part of our nervous system. There's so much the sensory system, the nociceptive system, but it is by definition subjective, and when the patient says they have pain, that's the ground truth. Biomarkers are useful to look into mechanisms, but never to ask the question, is this pain real or not? Each pain is as real as any other pain. The different ways of classifying pain. So the first classification would be acute versus chronic, which is a temporal definition, but also a functional one. Acute pain has a warning function, at least initially, but then it's mandatory for ethical reasons to also manage acute pain, because it's not ethical to keep people suffering. Chronic pain has no warning function whatsoever, and here we distinguish chronic primary pains and chronic secondary pains. Chronic secondary pains can be conceived as symptoms of another disease, like rheumatoid arthritis or, let's say, diabetic neuropathy. However, even when they are kind of a symptom of a disease, they often require their own management. And the earlier you try this management, the better for the patient. And then there are conditions like fibromyalgia or migraine or complex regional pain syndrome, where there is no other underlying disease. And then the major aim is to treat the pain condition. And that's what we call the chronic primary pain conditions, we being actually WHO. Since, as I mentioned before, pain is defined subjectively, the measurement is patient-reported outcomes. You ask the person who has the pain to communicate to you about their pain. And it's very important to know that pain is multidimensional. As I mentioned, it has sensory and emotional aspects, but it also has aspects of interference with daily life. And not only the intensity, but also these other aspects are very important to judge whether management of the pain is necessary or self-management will be sufficient. And then for pain mechanisms, we can measure other things. For example, sensory processing, for example, dynamic quantitative sensory testing by looking at the responses to stimuli and the changes in sensitivity that involve brainstem mechanisms. Those are tests, but the ground truth is patient-reported outcome. To be honest, the major challenge is that, as people said here, pain is everywhere and nowhere. So everybody knows pain is a huge health problem, and therefore nobody takes any action. If you look at the global burden of disease studies, there are two conditions that cause the biggest suffering, and one of them is back pain alone, and the other is depression. If you look into the amount of research done into depression mechanisms and the amount of research done into back pain mechanisms, let alone visceral pain or other pain mechanisms, neuropathic pain mechanisms, it's quite strange that not more money is put into pain research. In turn, since risk factors and mechanisms overlap to a certain degree with mental health, we can learn a lot from mental health research in setting up these programs.